Who knew that the importance of telehealth and complex rehab would have risen to such a high prominence over these past few years? Surely the public health emergency was the catalyst that possibly pushed this resource to the forefront. Now that we're edging around the corner of the public health emergency and even the variant just a little bit, will telehealth still be a critical piece of complex rehab, and how will this happen? Seemingly, telehealth had to overcome its own reality, right? For many years, the question if telehealth was even real was echoed in the halls of the largest hospital networks, insurance companies, and definitely in the post-acute care providers. The public health emergency changed that perception to a reality. Well, hello, friends. This is Coach Ty Bello, and today we are honored to have joining us Dr. Scott Martin, the Medical Director of TeleHealth Clinical Evals, and Maxine Paul, the Vice President of Operations for TeleHealth Clinical Evals as well. Welcome to both of you.
Hello, Ty. Thank you for having us.
Maxine,
thank you very much,
to speak with you. Doctor, thanks for being here. Thanks for making the time for this. I really think this is a great topic for us to talk about. And I've got a couple of questions that I'd like to just kind of throw out there and ask you. So first, let's provide some context to our listeners, if you would, on the background of telehealth clinical evals, and maybe share a little bit about your background and the genesis and maybe the inspiration for telehealth clinical evals as well.
Ladies first.
Oh, thank you, Ty. Hi. Well, as you know, when the public health emergency hit, it kind of threw everybody for a loop, and we all just panicked on how we were going to treat our patients and run our operations. And so we basically, went from being out there every day in the public to a complete halt. And so I just started looking at a lot of the regulations that CMS was putting out, and noticed that there was CMS put out a 1135 waiver, and that waiver had a lot of flexibilities, one being home telehealth visits in the home. And so I said to myself, gosh, what would I do if I was in this business? I told my husband, we need to look for a doctor that can help see these patients. And so that's kind of how the genesis started. We just went out there and tried to find a way to help the providers that we work with and coach, and we found Dr. Martin.
Doctor, how about you? From your point of view, how is this the genesis begun for telehealth clinical evals?
So Ty, again, thank you so much for your time. Just for a little background, I'm Dr. Scott Martin. By training, I'm a physical medicine and rehabilitation doctor. I am boarded and certified in interventional pain medicine, and I come from a long line of physicians. I think we have 15 or 17 doctors in our extended family. I practiced for 9 years in Southern California before I came to Las Vegas in 2015. For the 9 years in Southern California, I was a very, very end-of-the-road pain doctor. What that meant was I was port of last call for end-stage oncology, end-stage narcotic and substance abuse, end-stage post-operative and post-trauma pain management. And about 30% of my practice was devoted to each of those sections. The other 10% was devoted to taking care of patients that nobody else could take care of or knew how to take care of. And so, if it was an esoteric pain condition that somebody else couldn't figure it out and they'd gone everywhere, they came to see me. When I moved to Southern Nevada in 2015, I had been working for 9 years, about 14, 16 hours a day, 6, 7 days a week, and decided to put my family first. Moved to the pain community here in Southern Nevada, and this was right at the height of the narcotic epidemic here, and where a lot of doctors were very eager to position themselves for that epidemic. I took a completely different tack, and in 2017, I actually opened the first non-narcotic pain clinic in all of Nevada, and was very successful with that, and was very busy with that. I saw a lot of personal injury patients. That is up until the pandemic started, and I can remember as clear as I'm sitting here that on a Friday I had seen 30 patients, and the following Monday, when the pandemic unquote started and they shut down the city of Las Vegas in Southern Nevada, I remember sitting in my office, Monday, no patients, Tuesday, no patients, Wednesday, no patients. And I had this recurring text message from a Maxine Paul that I had met one time. And she was unbelievably persistent, always delightfully pleasant, but very persistent. And it was on a Wednesday at about 1 o'clock in the afternoon. And I finally called her back and I said, Maxine, tell me a little bit more about this wheelchair evaluation that you need help with. And she gave me a gentle introduction to that. And she said, would you be available to do an evaluation today? And I'm like, well, I got nothing else to do. I said, I haven't done an evaluation over 15 years. Is that okay? And she's like, sure. She's like, you've done it before. So it's kind of like riding a bike. It'll come back. Well, the first patient I interviewed probably took an hour and a half. And that patient was a Parkinson's patient. And she ended up giving me 3 patients that day. The second patient was a young child with cerebral palsy. But the third patient is what changed the course of my life. And that was a quadriplegic patient on the island of Samoa. He was very poor, and he was interviewed outside. He was sitting on a wooden park bench. He was a little over 400 pounds, and because his family couldn't afford a wheelchair, they had drilled that park bench into skateboards, and that's how they got him around. I've taken care of all sorts of oncology patients, both adult and pediatric. I've seen patients after horrific accidents and horrific surgeries, but I've never felt any more helpless than I did on the other end of the phone with this poor gentleman with all manner of awful pressure sores from sitting on a wooden park bench for years. And I thought I just have to do something more, because if this is just one gentleman out there, and obviously these other 2 people needed my help as well, I think I have a bigger calling. And that was the start of a very long conversation with my wife and my family, and an even longer conversation with Maxine and Bill Paul.
What a journey, doctor. Thanks so much for sharing that. And I really, really believe that builds a lot of context for what telehealth clinical evals is really all about. And thanks for sharing that so much. And Maxine, thanks for your persistence on reaching out to Dr. Martin and getting him on board. And just look, in a period of 3 evaluations, he kind of caught the vision. So Maxine, you mentioned, if you were a provider, well, you were a provider once upon a time. We know that, right? So how do you believe telehealth clinical evals today benefits patients, providers, primary care physicians, and clinics? In your words, how do you think it benefits them?
So one of the biggest obstacles we have is being a CRT provider is, making sure that they dot all the I's and cross the T's. It's really, difficult to go back and forth to the doctors and therapists to have them be on the same page and not have a conflict in their chart notes. So the biggest benefit is that the order is done right the first time. It doesn't have to go back and forth for corrections. Our team is competent in the process, and we're assuring that the evaluation is up to Medicare regulations, Ty. Every line item is justified. So we're making sure that, if the patient has postural symmetries, they're documented. If the ulcers are there, they're documenting how they transfer. Everything is in our evaluation. So the Medicare regulators can review our evaluation and see that this patient clearly qualifies. Another thing that's benefiting the patients is that they're getting their equipment a lot faster. We have seen the patients get their equipment under 30 days and some at 15 days. So it's a game changer for this industry, and it's unheard of. So we're really excited that we can make this kind of change in our industry. We feel like we've been kind of pioneers on this side of how we develop this program, and we're real excited to go forward. One thing about what benefits the providers is that they love how fast the process goes and how we collaborate with their ATPs. They don't have to worry about Medicare coming and taking back line items because, like I said, we code everything, we justify everything. For the primary care doctors, we basically, it's like the red carpet. They're telling us, take the patients, we don't have time. This is too much documentation for us. So they're on board. They send us referrals all the time. They love the fact that their patients are getting the equipment. A lot of times when we were a provider, we would hear from the doctor's office saying that you have to go see a specialist because our doctor doesn't do wheelchair evaluations. And, you know, clearly there's not enough specialists out there, but we would just have to convince them that it's their responsibility to do it. But with this new program, we don't have to do that. We're getting these evaluations done through the telehealth with Dr. Martin seeing them and all of our other physicians. We have a whole team of physicians now that we've built over the last year and a half. For the clinicians, they're just happy that their patients are getting the correct equipment that they need and it meets their medical necessity. And then an update I wanted to talk to you about today. I just found out that a patient that called us said that their primary care doctor could not see them until October. So you're going to see more and more where the primary cares are just overwhelmed with, you know, their own patient load, and the patients are just going to be pushed out further and further, and that could really put the patient in harm's way. So this is a real exciting thing for our industry to help our clients.
No, absolutely. What an advantage that we now are able to provide for both the providers and obviously for the patients. I mean, we're changing lives every single day with this opportunity that we've got. Doctor, one of the questions that I actually had was about you and, you know, you moving from pain medicine that you were in for 15 years and coming on board with TeleHealth Eval, but you really did that in the first part, which was wonderful. Again, I really found myself really being drawn to your story, but you just heard what Maxine framed up for us on the benefits. And now for you, you know, as doing thousands of these with the rest of your medical staff that you've got, you know, from your vantage point, your seat, how do the providers and the primary care physicians and clinics, how do they benefit from this? What do they benefit from the TeleHealth Clinical Evals?
You know, the benefit is actually fairly profound. And I'll try to make this blunt because I'm from Missouri and that's just how I am. The care of medicine has really fallen by the wayside because medicine is now predicated by the dollars. Primary doctors are literally seeing patients in 5 to 7 minutes, and they're doing so because they're reimbursed so poorly. Your managed care plans here in Nevada are reimbursing a primary doctor around $10 to see a patient with all sorts of complex issues. And these doctors are trying to figure out how they're going to run a practice. How are they going to pay their bills? How are they going to send their kids to school, you know, let alone go on vacation? And so what ends up happening if a patient needs a wheelchair is that the patient is seen by their primary doctor. They're referred to a specialist from the primary doctor. That specialist has to schedule the patient. Patient gets seen, gets sent back to the primary doctor. Primary doctor sends them to a physical therapist. Physical therapy appointment has to be scheduled. Then they have to go back after the physical therapy session and the evaluation, see the primary doctor a third time. And then the primary doctor has to take the report from the specialist and the physical therapist and then put together a summary report that primary doctor is not reimbursed for. So as you can imagine, that primary doctor has a massive stack of paperwork that he is completely uninvested in doing, simply because he's overwhelmed. You know, he's seeing patients every 5 to 7 minutes. He's very poorly reimbursed. He can't afford really good support staff or the support staff that he could 5 years ago because reimbursements for doctors go down about 5 or 10% every year. So that evaluation for that patient, whomever that may be, sits on a stack of about 2,000 sheets of paper. And unless that patient is calling that doctor and making his life miserable, that summary report doesn't get done. And usually if the summary report is done, it's done poorly, it's done ineffectively, and it's done in a manner that engenders a Medicare audit, and usually that chair is not approved. What we do is very simple. We are we are the almighty Atlas lifter. Literally, we pull the weight off the primary doctor's shoulders. We pull the weight off the provider's shoulders. And we say, all right, we're going to do everything. Bill Paul's a genius. He created a beautiful, CRT integrated system called Atlas. And by way of his genius and just hard and dedicated work with Maxine, the three of us put together a seamless proprietary protocol, all Medicare based, all Medicare driven. And what we do is take the weight off the provider's shoulders, the patient's shoulders, and the doctor's shoulders. So the doctor no longer has to do evaluations he's not reimbursed for and doesn't have time to do. The providers have a seamless one-stop shop for all the information for that patient and all the documentation that needs to go to Medicare. And patients who are already disabled, who already take 2, 3, 4 hours just to get up, dressed, get in the car and get to a doctor's office, don't have to do any of that anymore. And they can be seen in the comfort and the confines of their own home. And I don't know any patient that would rather sit in a doctor's office for 2.5 hours with bad TV and bad coffee, waiting for a 5 or 7 minute office visit and a $45 copay, that they would rather do that than be seen at home. None of them. So we really kind of, rounded third base and hit a home run on this because everyone benefits and everyone's been elated with the process.
Well, having understood this from the early stages of clinical health, telehealth clinical evals, I can tell you that I believe that what you are doing is transforming the industry, as Maxine and Doctor, as you've just said, but it goes beyond just what we've talked about, the provider. It also goes to that physician as well, the physicians as well that are out there. And so I'd like both of you to kind of answer this, because this was one of the questions maybe I posed at the very beginning. Telehealth has obviously become very popular, and we've got telehealth clinical evals, and there's a differentiator for us. Because as you know, there are others now that are coming into the marketplace. So my question, and ladies first, Maxine, you go first, please. What differentiates telehealth clinical evals from other maybe similar providers that are in the marketplace today?
Sure. So we have a team of specialists, Ty. We have doctors, we have OTs, PTs, we have ATPs on staff, we have that have SMS also. We have clinicians, and we all have a basic knowledge of the LCDs and the equipment training that we provide for all our physicians and staff is incredible. I come from a background of 20 years doing CRT, and so I'm kind of the leader and making sure that they all understand and know exactly what's necessary for the diagnoses based on the equipment, based on, their postural symmetry. So we also have a review process that the evaluation will go through to make sure that everybody is spot on. We've had I want to say one denial, and we've done thousands of patients since the pandemic. And that denial was because one of the providers didn't follow our recommendations in our report. And so Medicare denied them. But for the most part, we are seeing, every patient get their equipment. We are, if they've had a denial in the past from their previous documentation from another physician, and we can go in there and we can reassess the patient and speak to that denial. I mean, we have a lot of different benefits to our program besides just seeing a patient for a wheelchair. We do peer-to-peer evaluations with the private insurances, things like that. Dr. Martin's been instrumental in just, helping turn around denials, and he does quite a few. So I'd say that's what makes us stand out.
Doctor, how about you from your seat? What do you see differentiates telehealth clinical evals from others that might be out there today?
So I'll echo what Maxine said, but I'll put a finer point on it a bit. When you're trained as a physical medicine and rehabilitation doctor, you're trained to work as a team. I think there are a lot of telemedicine companies out there. They're not working really as a team. and they're working on a profit-based model. So they're kind of picking and choosing what they're doing based on what benefits them financially. They're cutting corners where they need to. There's something in medicine that we call disease-specific treatment and disease-specific therapy. If you are a patient that has complex medical needs, and you need a wheelchair, you need a hospital bed, you need a low airless mattress, you've had a wheelchair evaluation that was done in a rush or done inadequately, there has to be a peer-to-peer. In order to get things done on a patient-centered model, where the patient comes first, you have to do it as a team. Specific to what Maxine has said, our team is robust. It operates on a very slick and very consistent paradigm. Patients come into the system, they go through an adjudication process. Patient is seen by a physiatrist. They're not seen by a general doctor. If they are seen by a doctor other than a physiatrist, they're seen by a movement disorder specialist and a physical therapist. Our team is built around this type of patient care. Once the patient is seen by a specialist, that evaluation is then adjudicated once more. After its second adjudication, it's then reviewed a final time before that information is even sent to Medicare. We basically adopted the team approach of patient care for disease, and we applied it in a telemedicine setting. And then we took all of that and we structured it in a beautiful, seamless, cloud-based model that was designed by what can only be described as a genius, and that's Maxine's husband, Bill Paul. At the end of the day, what separates us is 20 years of experience in CRT with Maxine, 20 years of internet programming, design, and seamless integration by William Paul, in my 16 years of medical background taking care of maybe some of the sickest patients, in the southwestern United States.
What a story. I can tell you now that this will not be our one and done podcast. There's a lot more information that we absolutely have to share that we're not going to get to today, because we want to keep this to a specific time limit so that folks will listen to it, adhere to it, hear the message that you all are trying to bring to them regarding telehealth clinical evals. And by the way, you've done a great job. You've packed this time that we've got together full of real application for both the providers, the clinics, ATPs, all of the above to consider. So now, how does a provider, a CRT or a clinic contact you? How do they reach you all?
So they can go to our website, which is TeleHealth Evals. They can register as an ATP, register their CSR, and then if they want to send patients to us, they can have the patients reach out. They'll have to sign up in our portal, and we take them from there. But if they need to reach out direct, they can reach me at Paul at telehealthevals.com, and Dr. Martin at smartin at telehealthevals.com.
And I've got a phone number here. We'll make sure all of this is connected, but I think it was smartinmd at telehealthevals.com. But we'll get all of this in with the podcast. It'll be on the site where folks are going to be able to download this, so they'll be able to see it. So we'll make sure that happens. Any last piece of information or ideas that we can share with our listeners today? Dr. Maxine?
Sure. I think at the end of the day, what's important to everyone is independence. And if there's anything that we can do to improve your quality of life and improve your independence, we would be honored to help.
And I'll just say, Ty, that this is a game changer for the mobility industry. Being able to zoom into their homes and look at their environment and how they're transferring and how many care providers are there, taking care of them. We really can see all that. We can see the need, and that just makes us move a lot faster. I think when the patients used to go to the doctor's office, the doctors would just see them in the clinic setting. They never saw their home environment. So I think it's an eye opener for Dr. Martin to be able to see how they're living and how their support services are. You know, I just love it. I'm grateful that we found Dr. Martin. He's been a godsend to this model, and glad to help any patient that wants our help.
Well, that is great. Thank you. Thanks for all of the information that you've shared. Again, there's going to be additional podcasts, folks, so please continue listening. Stay tuned. So for now, this is Coach Ty Bello. Thanks so much for your time. We value it greatly. We hope you've received some valuable information from this as well, and we'll look forward to speaking with you very soon. Bye-bye.